postponed and having just gotten over COVID. So I appreciate you guys being flexible with me. If at any point my connection is choppy, please just put something in the chat and make sure to let me know so I can figure it out on my end, okay? And I think Dr. Richards is he also joining virtually, Chief Hartley, or is he there with you guys?
He's here with us.
Okay, awesome, cool. So Dr. Richards, please just speak up if there's anything that you want to add. And the only other thing I need, I think, from the admin side is the ability to share. Whether that's making me a co-host or just giving me the ability to share my screen.
Hang on 1 second, you just said it.
Thanks.
Right now, Alex.
Awesome. All right. It's great to see a bunch of you guys there. Hopefully you last for the next hour and a half. Keep my fingers crossed that you can all hang out. The 75s look like they're preparing for the coming apocalypse with all the boxes behind you. But we'll go ahead and get started. All right. Cool. So this is CQI. It's January, not December. Sorry about that. And we're going to start off with the hard stuff and then talk about easier stuff later on. Sometimes I end with the depressing diagnoses, but we're just going to start off with the tough stuff, and then it'll be easier after that. So it seems like every month that I'm reviewing your guys' charting, it seems like there are kind of themes that emerge. And the past month there were several dead on arrival and resuscitation not attempted calls. And so we're gonna just go through kind of some of those calls and some details around kind of like some pitfalls around documentation for these patients, and actually also an update to the 2024 protocol when it comes to hypothermic arrests. So this is directly from the protocol. So basic or advanced cardiac life support must be started on all patients who are found apneic and pulseless unless one of the following criteria are met. So if there is a valid DNR that is presented as defined by that particular protocol, if there is an injury incompatible with life, and these are like really very impressive injuries. So decapitation, hemicorpectomy is like half your body is missing, you're burned completely beyond recognition. And the key here is that really isolated penetrating trauma should rarely be considered incompatible with life, unless you have the history of a timeline that means it's been ages and you have maybe one of the other findings, like the next bullet point, which is rigor, dependent lividity, or decomposition. But even an isolated GSW to the head can be compatible with life, just depends on the circumstance. So sometimes I've seen isolated chest or head injuries kind of called and no resuscitation attempted, but we should really be attempting in those situations. If you really can't tell that the person is a person anymore, then that's considered incompatible with life. So it has to be pretty extreme to meet that criteria. We're going to go into the details of what rigor, lividity, and decomp kind of really involve and kind of how to document that stuff. And then in the case of an MCI, then there are specific MCI triage protocols that might mean you don't attempt resuscitation on a patient who otherwise normally would have. So that would be a special circumstance as well. So this is the first case. The patient's wife was found the patient not breathing with no pulse in his bedroom, called 911 and began bystander compressions. He has ALS and is in hospice care and was last seen alive in the late evening. On the assessment, the patient's found lying on his bedroom floor with his wife performing chest compressions. His pale, ashen, cold to the touch with evidence of lividity and rigidity presenting. The patient's pupils are fixed and dilated, no capillary refill, And the patient's wife said that they had fallen out of bed in the late evening last night, left him there to sleep with a pillow and a blanket, and found him pulseless and apneic in the morning. They were confirmed pulseless, rigidity and body temp, placed a 4-lead EKG to confirm there's no electrical activity, got their information and confirmed DOA, and then left with the police. So I think some great things about this documentation is kind of trying to identify a little bit about the timeline, right? Just because the last time someone saw someone was the night before, you all know that doesn't necessarily mean that they're gonna have died so long ago that resuscitation isn't warranted. But this timeline really helps to kind of describe what happened, why kind of decisions were made, and then they document the physical exam findings of rigidity and lividity as sort of required by the protocol. So, and there were no issues with like how things went in this case. I just felt like you had seen several of these this past month that it was worth talking about. So I'll put that kind of caveat in now. The second case was a dispatch for possible non-breather on scene, led to the patient by his wife. The patient's laying supine in bed, was pale, rigor mortis has set in, and the patient had lividity of his back. The patient's wife explained he'd been having an arrhythmia and cardiac issues for the past few days and complained of weakness and a cough the night prior. The patient was last seen responsive at 11 p.m. and had a history of AFib and was wearing a cardiac monitor. Also had CHF, hypertension, and Parkinson's. The patient was laying supine in bed, pale with fixed pupils that were equal. The patient was cold to the touch and had lividity along his back and was found to have rigor mortis in his head. The wife also explained that the patient had a valid DNR, so no rescue efforts were performed due to the findings and the DNR. The patient was covered up, left with the wife and handed over to police. So again, great documentation of this patient's his like immediate history as well as medical history, and then kind of documenting that not only were there findings consistent with rigor and lividity that warranted no resuscitation, but also being presented with a valid DNR. So two conditions met in that situation. And again, good documentation for this case. And then the third case was an 85-year-old for dispatch for expected DOA. On arrival, the patient was found unresponsive, pulseless, apneic, cold to the touch, and rigor, and was in a chair. The neighbor explained that she hadn't talked to the patient since yesterday and normally checks on the patient because she's been sick recently. When the patient didn't respond to the neighbor today, she came to check on her, was cold and stiff in the chair, and called 911. And then they didn't perform any resuscitation efforts due to the exam findings, and again, handed over to PD. So a briefer kind of narrative, but still sufficient, right? Still explains who this patient is, what their medical history is, if there's details for that, and sort of the timeline of events, which is really helpful. So we're going to go through kind of the details of what actually happens after death to just remind you. You guys see plenty of this, but I think sometimes it's helpful to go back to the kind of basics of like really what is happening and why. So the earliest changes after death is called pallor mortis. That is when patients just are pale in appearance, and that becomes apparent pretty quickly, like within 15 to 30 minutes. The next is algor mortis, which is being cold to the touch. The entire process takes 18 to 20 hours for the body to go from normal body temperature to whatever the temperature of the environment is, because really all that's happening is that the body and the environment are kind of equalizing. But obviously you can feel that much earlier than 18 to 20 hours, and you can feel it pretty soon after death. The next main one that has some more kind of like detail and nuance to it is rigor mortis. And this is the stiffening that takes place. And I always think it's sort of paradoxical, right? Like, why would the muscles contract after death? And the reason is actually that in order for muscles to relax, that requires energy. So immediately after death, the muscles relax, but then in the first 1 to 2 hours, you start to see this stiffening, and that's because there's no longer the energy required to actually move electrons and move calcium, specifically calcium ions, across the membrane of the muscles to relax the muscles. So you get this kind of progression that usually follows a predictable pattern, starting kind of at the top and moving its way down the body. So you first see it in the eyelids, then the neck or the jaw, the upper limbs, the belly, the lower limbs, and then finally the fingers and toes. So kind of up and down and central to peripheral. It starts 1 to 2 hours after that death is completed. So the whole body is stiff after 12 hours and remains that way for another 12 hours and then goes away over the next 12 hours. So for people who like charts more than just words, this might help as well. So rigor starts within the first few hours, is complete in 12 hours, and then over the next 24 hours, basically, you start to lose that rigor. So this is important if you come to a scene where you're documenting either lividity or decomposition. Say the patient's been dead for several days. Every once in a while, I see that documented along with rigor, and sometimes the timeline doesn't quite fit. And that's why the timeline is helpful for you guys to understand, okay, what might I be expecting in this patient? But also, does the documentation make sense, right? Yes, we're following protocol, but not every patient meets every single one of these criteria, right? You just want to make sure that you're documenting what you're seeing and what's there, because the changes are going to evolve over time. And for rigor mortis in particular, it can be helpful to document the precise location. So in the second case that we talked about, they documented specifically that the findings were in the head. So that kind of gives me a sense of timeline as well. I'm not, we're not investigating these from a kind of from that perspective, but it is helpful to make sure that the documentation, the findings, and the story all match. So that's rigor mortis. The next is liver mortis, which is the lividity, which is that skin discoloration. And this just happens because blood pools in as a result of gravity after the patient dies. Actually, at first, the skin will look bright red, and then after some time, it changes to kind of like a blue-purple, like bruisey appearance. And this can take about 6 to 8 hours. So you absolutely can have lividity and rigor mortis in the same patient. And remember that lividity is going to be kind of in the dependent locations. So for that patient who was found in the chair, I would not expect lividity in their back, like most of your like nursing home patients or patients who die in their sleep, where most of the time the lividity is going to be in their back. You're going to expect it wherever gravity is kind of pooling that blood. So someone who's in a chair, maybe in the feet or the buttocks, rather than in the back. So remember to look in those places and examine those places as well, rather than sort of what might be the default or the typical, which would be usually in their back if they've been laying down. And then the final finding is decomposition. And this is just cell breakdown and bacteria that kind of start to work on the body, and usually becomes apparent in the second day post-mortem. So again, you absolutely could have decomp and rigor at the same time. You're very unlikely to have like advanced signs of decomposition and rigor. And so some of the pitfalls that I have seen in documentation around DOA patients is that it's really helpful to document the scene well and document their last known well. And these, again, just help us to understand what we would normally expect for that patient, and maybe the timeline of events. And then document what you see, right? You don't need to say they meet every single criteria, because not every patient is going to. You just need to check off one of the boxes to be able to meet the protocol criteria for not attempting resuscitation. And be specific, and this is particularly important with like the location of rigor mortis. And whether or not with the timeline, does it make sense that two different processes are happening at the same time? It might, and that's fine. Just document what you're seeing. One other comment on rigor mortis is that some patients in cardiac arrest can have a really tight jaw as part of the acute kind of cardiac arrest process. I'm sure you guys have had patients where it is really difficult to open the mouth to get in the supraglottic airway or to intubate the patient. And so recognize that just because the jaw or the mouth, the jaw is stiff or the mouth is difficult to open, that may not be enough to say rigor if the rest of the circumstance doesn't make sense with that, and not to stop just because the jaw is stiff. If you're starting resuscitative efforts, and that's the case, keep going, bag, valve, mask, and attempt to open the jaw, but you can keep bagging the patient if you need to. And then along the lines of sort of documenting two different types of like rigor and decomp, like we talked about, is sometimes I see conflicting documentation. And I think part of this is probably your PCR, your electronic PCR in some ways, that it's hard to document, like I felt for a pulse, but there was none. But sometimes I've seen like vital signs weren't assessed, but then documented, that there's no pulse, right? If you're feeling for a pulse, that's a vital sign. It's not particularly vital in that moment, right? It's absent, but try to make sure that the different parts of your documentation match up. Same thing if you are getting an EKG, which is not required if you meet the other obvious signs of death, but if you do decide to get one to document the rhythm, that's the heart rate and the vital sign as well. So just make sure that if you are documenting asystole, that you've actually gotten an EKG, and that you're trying to use the PCR to the best of its kind of abilities, to document all of your findings and not have conflicting information in different parts of the chart. All right, so it's 2024 now, the new protocols are available. I don't think they've been uploaded to the website yet, but they are done, and the kind of information around the protocol changes has come out. One of those was to the hypothermic arrest algorithm, which I actually presented on in the fall of last year. So we used to recommend that in a hypothermic arrest situation, that you space out epi and limit the number of shocks. The new guidelines basically have made everything simpler. So now you just follow normal ACLS procedure for cardiac arrest in the case of a hypothermic arrest. So again, a patient might be cold because they've been dead for a while, or they may be cold because of some sort of exposure, and then they fit in this category of a hypothermic arrest, where the concept of you're not dead until you're warm and dead comes into play. So again, that's where your history taking and the kind of information about the scene are particularly important, because if it's been a cold weather drowning, if it's a patient that's been out, either maybe a homeless patient or something like that, where just exposure to the elements is a likely cause of their cardiac arrest, or little old lady where their heat went out, something like that. But if they're cold because of some sort of environmental exposure, then you want to initiate resuscitative efforts, and actually transport on the sooner side, because the key is that patient needs to be warmed, and the best way to do that is through sort of invasive means in the hospital setting. And the change again to the 2024 protocol is really just making life simpler, that now you just follow normal ACLS cardiac arrest guidelines. So routine epi administration, other meds if you have an arrhythmia, and normal number of shocks, just like you would always do. Okay, but again, rather than calling it the scene for those patients need to be transported so they can be warmed in the hospital. Dr. Richards, do you have anything else to add on those charts and those patients?
No, I'll just kind of amplify a couple things that you said already, which is especially if like the timeline from the scene doesn't match your exam, like write down your exam. Like I have to imagine that, you know, a savvy person taking a review of this, if someone on scene was like, oh yeah, they've been dead for 4 days, but like you're seeing like true rigor in your chart, like write that down because
Yeah.
write the information that's good later on. Two of these presumably had DNRs. I think the approach was done quite well, especially in the first one where the patient was in hospice. Like it's kind of a bummer that, you know, CPR was initiated, but we see that, of course, right? I mean, for any variety of different reasons. And so I think kind of bringing the wife or the patient through that process. Sometimes it really is, I don't have to tell you guys this, but you know, sometimes it really is like either just like a panic or I don't know what to do logistically next. So we're gonna give you guys a call even if they are in hospice. And then sometimes there actually is like some thought of like chest compressions and coding as being kind of like a ritualistic approach to like end of life in some respects. And so especially with like how it's portrayed on TV and these sort of things, sometimes people almost see that as like, this is our like death ritual now, so you have to go through that process for some people. Not entirely, of course, but so you know, I sometimes wonder. I find interesting kind of the intersection of hospice and end of life care and what we do in the field, and so that is that's some of what's been reported.
But go ahead. Along those lines, we've had over the years like conflicting information regarding DNR. So if we show up, I have a DNR, I gotta go find it. What do you want us to do? If we suspect that, yeah, they in fact do have a DNR, they're going to go find it, like not a, you know, crime necessarily, right? Like they gotta go look for it, they don't know where it's at. What do you want us to do?
What I would say is if it's like so the protocol first would say you need a valid DNR. I think from my perspective, if it's like you get a good sense from the scene and they're saying 100% DNR and say like, you know what, like in absence of this piece of paper, I really gotta do my job. And they're like, no, absolutely not. I actually would be okay with you guys holding off on that. At the same time, that's probably not a universal view of how someone else might view that scene. And so I want you to be cognizant of that, because what I sometimes worry about is, you know, everything seems fine right then and there, and then you have like the out of town like sister or something like that who comes in and they're like, oh, wait a second, like you wanted everything done after all, you have the paperwork and stuff. But at the same time, like I would really hate to inflict, you know, that amount of discomfort either for the family or the patient, like in that circumstance. So what I would do is say along the lines of, I agree. I hope you can get that paperwork because I kind of have to do this otherwise. But you know, if they're like, yeah, it's in the other room, like let them go ahead and get it.
And then follow-up question to that. Let's say it's a living will. Nobody wants to do that.
The protocol in the law technically does have to be like a signed DNA. And living will does get a little bit more complicated in terms of what it actually covers in terms of like this specific conversation. So I think if that's the situation, then I probably would move forward with this. If it's truly like a living will kind of situation. But if they're like, hey, we have this like 1-page DNR CC, it doesn't matter. It's in the other room. I think it was like, we really didn't get that degree of paperwork set, then I think you're potentially stuck. You could always call online, control and describe the situation. I think if it's a living will situation, they're probably gonna have you.
Okay.
Yeah, I think if I second sort of like call medical control if you're unsure of the situation. Most of the UC docs I think are pretty pragmatic, and you know, we all want what's best and what's right for the patient, while being cognizant of those potential kind of legal or other ramifications. So definitely if you're struggling with making the decision, just call. I think there's something else I was gonna say. Yeah, it's disappeared. Oh, and I think, and one of the other things, Dr. Richards, is to kind of start compressions only CPR for a minute while people are figuring things out. Is that, would you think that that's a reasonable kind of slightly, maybe
I think the
slightly less
only
invasive
thing-
option to like
I would-
get started and show that you're doing something?
I think the only thing that I would not want you guys to do would be like a slow code. So if you're doing like interventions, you know, are not going to work, even in, you know, a potential circumstance where chance of ROSC is probably overall low. If you're like intentionally doing like a compression like every other second, and you're kind of like half-ass, like that, I don't, that's not ethically justifiable in my mind. Now, if you want to do something where it's like, you know, you're gonna initiate a resuscitation, you think it's gonna be, you know, a couple minutes for papers to get documented, and you kind of just want to start with chest compressions while you're kind of getting out the bag, you know, your left bag and all the rest, like that, I think is reasonable. But I think if you do like a 30-minute slow code and then call it like that in my mind, I don't think it's justified. Either do it or just. Or don't.
Any other questions? Cool. All right. Okay, so the next patient that we're going to talk about was a patient who had a choking episode. And I think this was a very sort of, I could imagine in the moment, difficult situation. I think the decision making sounds like it was probably pretty difficult, just based on how the patient kind of changed and evolved, because they at different times fit in different parts of the protocol, and were difficult to manage, sort of like physically and agitation wise as well. So this was dispatched for a 70-year-old choking patient. On arrival, the patient's found laying on the kitchen floor with police performing CPR. And the family said that he started choking while eating prime rib. He has a history of COPD, asthma, multiple strokes with aphasia, as a lasting deficit, and resides in an assisted care facility with, and was with the family just for Christmas dinner. And they don't know if he's on a soft food diet due to the aphasia at the assisted care facility. The patient was initially unconscious, unresponsive, pulseless with agonal and obstructive respirations, but regained a pulse, and began having labored obstructed respirations after about 3 minutes of CPR. The patient regained consciousness, became combative, had a GCS of 5 for the duration of your care. His airway was mostly obstructed, with quiet but audible wheezes without a stethoscope. His skin was cyanotic from the nose down, diaphoretic, cool, and the paddle view EKG showed a sinus rhythm. After oxygen via nasal cannula and BVM, cyanosis got a little bit better, and his sats were 76% with a pulse of 98, and bounding pulses. Pupils were equal and reactive, and due to his mental status, it was difficult to assess kind of the rest of his perfusion. There's more to the kind of charting, and I'll finish going through that, but I just wanted to highlight kind of this section. And what I loved about this was, you know, whether it's a chart or someone presenting a patient for me or someone giving me handoff, you know, my mind is already starting to think while you're talking, while you're presenting that patient, or as I'm reading. And so as I read this, I'm like, oh, like he's got aphasia and multiple strokes. Like this person probably should not have been eating prime rib. And I literally was like in my mind, oh, I wonder, you know, if he's supposed to be on a modified diet. And then like there it was and documented. So great thought process on the part of the crew to try and get this information, and like really demonstrates some advanced thinking about, you know, like not just what is happening in front of you, but sort of the potential why behind that, or what the patient's risks were. So I just wanted to call that out as, you know, it's not it's not the documentation itself, but what it demonstrates to me is the thought process behind it, which I was really impressed by. So I wanted to kind of call that out there. So rest of documentation on this case, CPR was initiated, pads placed. So we're going back to sort of like the beginning here in terms of their management. Suction briefly, but then the patient started clenching his jaw. So here's your like first kind of challenge to managing this patient's airway. After about 3 minutes of CPR, before any rhythm assessment could be performed, he started moving, and so CPR was stopped. Totally reasonable, right? If patients start moving around or swatting at you, you don't need to keep compressing. They were placed on oxygen via nasal cannula with high flow oxygen and moved to the cot, was secured, and went to the squad. Vitals were obtained and assisted ventilations with BVM. You were unable to otherwise visualize or interact with the patient's airway after he regained a pulse, again, because he was clenching his jaw. And then sort of like the second issue here was that he was combative throughout transport, preventing like multiple different aspects of your assessment and management. So preventing inaccurate blood pressure, preventing IV access, and the patient had to be manually restrained to even just continue, what respiratory care you were able to provide. We monitored him, got him to the hospital, and shortly after handoff, the patient coughed up a large piece of prime rib and came back to his baseline mental status. The initial vital signs were pulseless, BVM for respirations and GCS of 3, and then the repeat vital signs, like was documented, was a BP that was not able to be obtained, a heart rate of 98, respiratory rate of 12, assisted with BVM, 76% on oxygen, and a GCS of 5. So really great documentation in this case, and kind of highlighting, again, like we talked about in the last slide, not just the thought process, but then, the reasons why interventions were or were not undertaken, and really helped, from my perspective, for me to understand really what was happening and why this was such a challenging case. So I want to highlight in the protocol kind of the optimal, I guess I would say, management in terms of like if you can do all these things. And then we're going to talk through like some of the nuances and things to think about if you're presented with someone who is the way this patient was. So the first is if the patient is pulseless and sorry, it's like cutting off the top of my screen. So the beginning part is if the patient is awake and obviously choking, then you can try, if they're cooperative, you can try and have the patient forcefully cough, can give supplemental oxygen, and then provide the Heimlich maneuver. And even if that's successful and the patient like goes back totally to normal after, would still encourage transportation. One, you can have post-obstructive pulmonary edema from bad episodes like this. You can have kind of smaller aspirated like pieces of whatever was aspirated still down in the lung that are a major infection risk, and those sort of things. And so we do still recommend that these patients get transported. The Heimlich maneuver, if you are, able to stand up with the patient and get your arms around the patient, and obviously you can do like the classic kind of like fist under the rib cage, pulling up and back kind of repetitively and quickly. If they are on the ground or they're too big, or their mental status isn't great, then abdominal thrusts are the kind of like the term that would be used. And so again, that's just under the rib cage, and pushing down and toward the spine and kind of up a little bit. Again, you're literally just trying to compress the stomach and kind of increase the pressure in the abdomen to like force whatever is there out. But remember that you do have an option if the patient is like not perfectly with it in terms of their mental status, but is still awake and moving. And or if the patient's body habitus means that you can't do the standard Heimlich. If the patient's unconscious or becomes unconscious during your assessment, then you want to go to ACLS, start CPR, transport early. If you can get a blade in to visualize and see if you can see the foreign body, great. If you can even then remove that with McGill's, even better. If not, suctioning, but obviously large chunks are not going to come out with sort of like the standard suction tips. And if you don't see an obvious foreign body and the patient doesn't start breathing, then going fairly quickly to intubation. And what is recommended if you still suspect foreign body aspiration is to actually like get the tube in really deep to like force whatever might be there into the right main stem, which is where most things are going to go if you put an endotracheal tube in too deep, and then pull back the endotracheal tube so that you can aerate the left side, and you kind of like don't worry about the right side in that moment, and someone else will deal with it later, kind of thing. So that's the optimal. This patient was, I think, particularly challenging because in some ways because CPR was successful, because there was never kind of the time or opportunity to be able to effectively visualize whether or not there is a foreign body, both because of the jaw clenching, like we've talked about now multiple times today, but also because once they become conscious, now you really don't have the option of putting in a blade and endotracheal tube, or even looking with the McGill's, because that's going to gag the person and no one's going to be in a good spot. So again, these are your sort of optimal. If the patient has a partial obstruction, is still awake, you're just trying to basically do BLS and force that object out. And if they become unconscious or pulseless, then CPR. So, you know, what are your options in terms of managing these airways? You know, we're going to go through the basics through the most extreme, and talk about kind of why or when different things might be helpful. So the first is your nasal airway, right? For a patient who is like awake, but still hypoxic or and potentially combative, they may tolerate this. Is it going to help you a ton if there's a foreign body like further down? Hopefully you can see my arrow like down here by the cords. Not necessarily, but it is a simple airway adjunct that would be reasonable to try and probably isn't going to make anything worse. Next would be your oral airway. Obviously, regardless, this is only for patients who don't have a gag reflex, which usually means unconscious patients. And in a situation where you're worried about choking or foreign body, it is not going to be the definitive thing that helps. So honestly, if they are obtunded and would tolerate an oral airway, you should probably just go straight to looking in their mouth with a blade and looking toward intubation, because you run the risk of potentially pushing something, you know, further in, and it's a blind insertion, right? So you don't know what you're doing. If you hit resistance, you don't know what you're hitting, and it's not going to help you more than what is really the mainstay, which is trying to actually see what's there and potentially get it out. Bag valve mask, great. You know, if someone is hypoxic and either obtunded or unconscious, right? This is our first go-to, and absolutely should be used as your kind of like initial management before you're able to do some of the more advanced things. A supraglottic or an LMA, I think, and Dr. Richards has seen kind of more of this, but this is a patient population where I think there's potential for more harm than good with a supraglottic device. Again, it's a blind insertion. You're relying on normal unobstructed anatomy for the device to seat correctly. And if there's something sitting right above the cores, it might prevent the device from seating correctly, or you might, push or move something that maybe previously would have been something you could get out with forceps that now you can't. And you're blocking the path for any kind of vomit or anything else. So just like the oral airway, if you're thinking, in this realm where someone's unconscious or you're doing CPR, the go-to is really to visualize with a blade and to look towards intubation. And this is just a picture of someone using McGill's. We're going to go to a website on the next slide to kind of look at the different techniques. It's definitely worthwhile pulling your McGill's out and kind of looking at what they look like and how you would use them in reality, because they're a weird shape and they're not completely intuitive, to be honest. So we'll go through on the next slide, like I said, some pictures of different techniques for using the McGill's. And then the final would be your surgical airway, right? So if you're in a can't oxygenate, can't ventilate situation and you're suspecting, maybe you could visualize something above the cords, but you can't get it out, or you're suspecting something, then those are the patients where actually moving to a surgical airway is appropriate. And especially, some of you guys are out a decent ways. You're not going to be able to kind of keep that patient stabilized. Obviously, it's your Hail Mary, but it is something to consider when it comes to can't oxygenate, can't ventilate situation. All right, so this, and again, let me know if the wrong screen is showing up, but I think I shared it correctly so that you'll be able to see this website. So rather than putting all the pictures in my PowerPoint, I chose to do it this way. So this is probably the way that I would see most people recommend using McGill's forceps. So it's actually holding them kind of like a pistol or a gun, and then being able to like rotate your elbow so that this bend ends up in the back of the throat. So you have good maneuverability this way. You keep out of the way of your visual field and your other hand as you're holding it. But it is, again, it's pretty counterintuitive. So I would definitely recommend like going and looking at your equipment and seeing what this looks like and feels like. And if you even have a mannequin, like shove something in there and actually try and go get it. If you have kids, a little Lego works, or the little like caps off of IVs or flushes are great for practicing kind of going after an airway foreign body. But this is what I've seen recommended most often, and kind of works the best to be able to give you the movement and the freedom of movement that you need for most patients. There are other methods. So this, again, the bend in the McGill's is like back here. It's just your hand ends up in the situation, your hand ends up kind of in the same place and potentially blocking your view a little bit. Obviously, if you have video, that's great. But if you're doing this with direct, your hand might get in the way and make it difficult to actually see what you need to see in this situation. But you at least get the McGill's in the right orientation. This one, I don't really even know why it's recommended in here. Like here, your hand is kind of angled this way. I mean, you lose a lot of your ability to kind of manipulate the fine motor stuff with this technique. Again, you're getting that bend in the right place, but it's going to be difficult to make some finer adjustments or, get the forceps in an upright position if that's better for getting at the foreign body. And then same thing with this one, just kind of awkward, kind of with how the wrist is. So you're not going to know until you pick them up and then realize like, oh crap, I need the bend in this position. And now this is how I'm holding it. Because this kind of optimal technique, again, looks a bit counterintuitive, like you're almost starting with it upside down, but it really gives you the range of motion that you need in your arm to be able to use the McGills effectively. All right, so that's everything that I want to talk about for that case. I want to give Dr. Richards a chance to add anything as well.
Yeah, I probably for the McGills, I would, when you practice it, you have like a airway tray or something like that, use that optimal method, and then if you ever have to like kind of troubleshoot stuff around, because even the way that the grabber part is kind of like rounded off at the ends and stuff, it kind of helps you negotiate that posterior oral failure as well. Yeah, this was super interesting in terms of how we were able to oxygenate, because it really was like compressions and vague valve mask eventually got to the spot where he was agitated, which is like a really good spot to be in, because I mean, if you oxygen to his brain enough that he was like agitated. So I think if he totally agree with you that if he continued on a asystole kind of pathway, then 100% we're looking. From when it comes to like the supraglottic, you made a great point about the oral airway. If you're in those situations, that's the time you bring out your laryngoscope and take a look and see you either pull something out, or if, as the protocol says, shove it down and try to like whatever that obstruction is. Because that really is like among like the important reasons why we have that laryngoscope in place, is for these kind of situations where you have an upper airway obstruction, maybe able to relieve by direct visualization just with the laryngoscope itself. So I would, had that vague valve masking and compressions or whatever it was on roots, not dislodge something enough to get some of that oxygen down, then I think we're definitely bringing out laryngoscope and taking a look at bring that primer back.
Just a note to add, I was on this run and I was on the engine, and we were talking about if he really is choking, maybe we get the King Vision out to see if we can get a visual on
That'd be
King
awesome.
Vision.
Yeah.
But obviously
Yeah.
we can't use it open to use that device on there, but we did plan on using that if you want.
That's right, you mentioned that too, yeah, and sometimes even, when it comes to the video laryngoscopy, sometimes that can be different geometry to get you in there as well. Like if they're clinched, you're not gonna get it in, but like what could be a little bit of a more difficult airway just from your Miller, you might get a little bit better view with the video, and vice versa, unfortunately. But I think the King as an option here was a good thought. We're open for you. or maybe you get to the point where like oxygenation kind of like open it up. He's agitated, so at that point his jaw relaxes. Then if he ended up kind of going down again, then maybe you don't have the same kind of like stiffening of that jaw, and then you have your opportunity to take a look at that.
Yeah. I don't know, Dr. Richards, if you've ever tried to use a McGill with the Miller blade. It feels like you'd have kind of competing geometry, like one curved device and one straight device, might kind of get in the way. I don't know if it's something you've ever had to try, but definitely like a Mac blade or a video blade with a curved geometry is probably going to be easier.
Yeah, that's a really good point. My standard go-to blade is the Mac anyway. I know everyone has their own preference. So I usually end up using Mac blades or video to begin with. So I'm usually a curved blade.
Yeah.
So all of the times that I've used the McGills on a patient, I would have had the Mac with me rather than the Miller. I guess that's a good point.
Yeah. Yeah, I've seen an adult choking patient come in this kind of like agitated state where they had gotten to the point of, like Dr. Richards is saying, like enough oxygen that they're not coding anymore, with still an LMA in place. And that was it was sketchy in terms of like, what do? You don't want to put this patient down now and sedate them necessarily, because you don't know what's going on. Is this airway helping or not helping? Is it hurting because now they're responsive and they have this thing shoved in the back of their throat? So it's definitely, a big part of this is finding those situations where the stuff that we have come to rely on that is extremely helpful for like 90% of your resuscitations may not be the right choice, and picking out that patient. So again, the documentation was super helpful for me to understand like why and what the decision making was. And I'm glad that you guys kind of talked through your options on the scene and thought about direct visualization early. That's fantastic.
And from a follow-up perspective, turns out he did totally fine. He was like back to his baseline mental status after a couple days in the hospital and went back. So he ended up doing well.
Hopefully to a soft diet.
Right.
Who knows? Awesome. Cool. All right, as has become standard, this is your pediatric education for CQI. Just because I have to. But really I think it's helpful to talk through this next case, mostly to kind of impress upon you guys the red flags in pediatric syncope, which patients, there's potential for badness. There's been, you may even have seen in the news, like multiple stories recently of, patients who have gone down, been resuscitated with an AED, found to have either an underlying arrhythmia or a structural abnormality, who've been saved by, bystanders in different situations, and, pediatric patients under the age of 18. So this is nothing crazy or scary happened in this case, but it did, I think, does provide some opportunity to talk about some of the education around this diagnosis. So this was a dispatch for a 12-year-old with a syncopal episode at a fitness studio. On arrival, the patient and the father are standing outside of the business. The patient was taken into the medic unit, alert and oriented ×4 with a GCS of 15, patent airway, non-labored breathing, normal skin, normal pulse. The patient's father said that she was shooting free throws when she passed out and went unresponsive. He advised that she was unresponsive for about a minute before she came back around. No pertinent no pertinent medical history, doesn't take any medications, vitals were normal, blood sugar was normal, and the patient was fine, had no complaints at that point. You offered to take this patient to the hospital, and after talking to another family member on the phone, they decided to follow up with their family doctor and refused additional care or transport. And the crew advised to call back if there's anything else that happened, and got a refusal signature from the father. Vital signs were normal, as was documented. So blood pressure of 124/86, a heart rate of 98, respiratory rate of 16, 98% in room air, a glucose of 123, and a GCS of 15. So I'm glad that you guys were able to kind of like basically get to talking to, both the father and the mother, and making sure that a good conversation was had around refusal in this case. I think, it's hard to know exactly what the conversation was. So my comments are solely based on like what's written here. So if anyone was here and wants to talk more about kind of how that conversation went, we absolutely can. This is a situation where if it was me on the scene, I would have been pretty explicit and sort of, I don't know if forceful is the right word. In my tired brain, that's the only word I can come up with, but kind of a little bit more aggressive about getting this patient to kind of more urgent care than just follow up with the family doctor. And if they're really not going to do that, and you've been able to have a good conversation, this is a patient who needs to abstain from any kind of physical activity until they're evaluated. Because based on the story of a syncopal episode during exertion, this is a high risk event. And what you don't want is for this kid to go to gym class 2 days later, pass out during gym class, and no one knows what to do. There's no AED, and this kid ends up, passing away because of some underlying issue that was present the whole time that is just now kind of rearing its ugly head. So if you've had a really explicit conversation with the family and encouraged, even if they don't want to transport with you, that's fine, but going directly to the ED that day for an evaluation, and they're not going to do that, then at the very least, they have to be counseled to avoid any kind of exertional activity. So that brings me to kind of talking about what the red flags are for syncope in kids. The first is a young age. So, under the age of 8 without a very good reason, any kind of syncopal episode is a red flag. Any syncope that happens during exercise, and this does not need to be, I was running sprints for an hour, or I was, doing insane weight training for football. Like, this is really any kind of exertional activity, and I would definitely put, being at the gym shooting free throws into that category. So any kind of syncope that happens during exercise in kids is much more concerning than something that happens with a positional change, or that even happens with rest. Kind of sometimes that feels a little bit backwards, but that's what put this kid in a high risk kind of bucket. Any syncope that is preceded or associated with chest pain, anything that's associated with a significant injury from a fall, if there was seizure activity and a post-ictal state, then that kind of raises your suspicion for either a neurologic problem as the actual cause, or a more significant arrhythmia. I think in one of my first CQIs, I showed you guys videos of these like healthy college students that they did an experiment with, and had them hyperventilate to the point of fainting, and then watched what happens. And you can have some weird kind of like jerking and twitching and stuff after just a normal vasovagal syncopal episode. But they usually come to right away. There's no like post-ictal state. So if there's really like movements that were concerning for seizure, or any kind of post-ictal, like they were confused for a little bit, didn't respond for a while, anything like that, then that would be a red flag and a more concerning event. Any kind of focal neurologic findings. And then there's this whole bucket of family history of red flags. And I put these up here again to not to tell you that you need to be getting all of this history. This is, I think, outside of, the scope of what you should be doing or expected to do on the scene. But we do dive in pretty significantly into family history on these patients when we see them in the ER. So more to impress upon you kind of the stuff that would happen if a patient with this kind of story came to us and was evaluated in the ER. So any kind of first degree relative that has any of these things: cardiomyopathy, early sudden death, heart attack at a young age, any known arrhythmias, anyone with a defibrillator or pacemaker at a young age, all of those things are things that we dig into when we're getting a history on these patients. And it's all to sort of elicit different potential causes of this syncopal episode. So as your history findings, there's some concerning physical exam findings. So anyone with a heart murmur, any other abnormal heart sounds, a rub, a gallop, anything like that. Any kind of differential in their pulses in their upper and lower extremities. If you've got crackles on your lung exam, their lungs sound wet, or they have a large liver or spleen. Again, these can be sort of nuanced physical exam findings. It is another reason why these patients need to be evaluated urgently. And then there's abnormal EKG findings. So for this patient, I think the thing that I would have added to the evaluation on scene is to have gotten an EKG. I think there was a blood glucose, but no EKG was obtained. And this patient, even though they weren't having kind of like your classic chest pain, MI sorts of symptoms, did have a concerning syncopal episode. So the one thing I would have added is definitely getting an EKG. The challenge with an EKG in the pre-hospital setting is, again, that some of the findings that would lead us to suspect kind of a worse cause of the syncope are kind of nuanced and not things that you guys are necessarily trained at to identify. So we're going to go through some of these and what these look like. Again, this is not to tell you that you should be able to assess for these things, because frankly, some of them are challenging for me, and I call cardiology for a bunch of them anyway. So because they're nuanced, going through this discussion is more to impress upon you, again, which patients you should be concerned about, what stories make us nervous, and the types of findings we might see in a patient with a history of syncope on exertion. So the first is a long QT. The second is a syndrome called Brugada syndrome, which is kind of a pseudo right bundle branch block, usually with some minor ST elevations and kind of a funny looking ST segment. The third is something called Wolff-Parkinson-White, which is a pre-excitation of the heart and comes with a specific kind of shape and wave associated with the QRS complex. Hypertrophic obstructive cardiomyopathy has signs of like a big left ventricle usually. And then, much less likely in a 12-year-old, but MI is certainly on the list. SVT is on the list, and bradycardia. This patient had a normal heart rate, so SVT and bradycardia are effectively ruled out, not as the cause, but by the point that you were evaluating the patient would have been resolved anyway, but they're on the list nonetheless. So this first one is an EKG with long QT. So basically a QT more than 450 in some cases, and definitely more than 480 would be considered long QT. And you're looking at the interval, the time between the Q wave and the T wave. I kind of like quick look as if the QT is more than half of the distance between each QRS complex. That might signal that the QRS is long. On our EKGs, they calculate them. I forget now on your rhythm strips if they, or on your 12 leads if they calculate them. But this would be a concerning finding. This next one is a picture of Brugada syndrome. This is a sort of like channel abnormality. So you get these EKG changes in usually V1 and V2. You get this kind of like humped ST segment. I think most of you would probably look at this and be like, well, that looks weird. But again, you're not trained to identify this and figure out exactly what it is that's going on. So this is one of those nuances that we would, have cardiology evaluate the patient pretty expeditiously if they were seen in the ER. These are some other kind of more nuanced findings of Brugada syndrome. So again, I don't know, would we catch that as a ST elevation? Maybe. This one, probably, but you're not necessarily going to have the same reciprocal changes that you're used to looking at if you're looking for an MI. So the ST changes may go kind of unrecognized. This one is Wolff-Parkinson-White. So this is called a delta wave, where it kind of the beginning of the QRS kind of slurs upward. Sometimes, like in lead 3 here, has kind of like this hump, but that's a sign that the heart muscle is kind of pre-excited, and again is a concerning EKG finding. This one would be hypertrophic cardiomyopathy, so basically signs of left ventricular hypertrophy on this EKG, and that's it. So again, I went through those EKGs pretty quickly because my goal is not to teach you how to assess for those EKG changes or be able to identify them by any means, but more to impress upon you, the types of things that we're looking for and the nuances in an evaluation like this. So again, with this particular patient, 12-year-old, syncopal episode during some kind of exertion, even if it was mild exertion, that patient automatically is going to go into a high-risk bucket, should definitely be evaluated in the ED. And if you really, really can't convince them, document the hell out of your conversation and make sure that you tell them that they are not clear, should not go back to any kind of physical exertion until they're seen by some sort of physician. But preferably they should be seen emergently rather than following up, in a week, 2 weeks, a month, whenever their pediatrician can get them in to see them.
Yeah, I agree. I was also kind of, just reading about the circumstances, been like, oh, this is like probably not good. Not even a PZ impact like that is. So, I think I 100% agree that I would have liked to see a 12 lead. Especially like in a gym or something like that. Inside might be a little bit challenging, but if you can like think creatively about like how to do that with some modesty, or if they're like outside, maybe in the rig, because maybe even that like action of doing the 12 lead may impress upon them. Like, hey, there might be something else I'm not thinking about, because probably for layperson, they may not equate like passing out without warning to something related to the heart. And so maybe doing that 12 lead may even make that connection to them. The other potential option you have to even further kind of your conversation about going or not going with them is to get the 12 lead, maybe even send that 12 lead to like children's space and have them have that conversation. Because even if we don't remember like all the different like things that we're seeing on the tracings, recognizing like high risk features of a pediatric syncopal event and having like someone on online medical control of children's have that same conversation, maybe end up having that conversation. Now, the flip side also is that like, following up with a pediatrician, hopefully is a little bit better than like, a 55-year-old following up with their primary care who may not see them for like 3 months kind of thing. Like, I feel like pediatricians like oftentimes have a little bit more kind of availability, and so they may truly be able to have seen their regular day or so. Now, this was at the end of the day, this is like a couple days before Christmas, so I kind of managed that situation. But I agree that if you didn't point about high risk pediatric syncope, may not be apparent to the patients or the parents themselves. And so having that conversation, as you guys did, I mean, at the end of the day, you're not strapping them down kind of thing, but it is a little less common of events, especially with this event. So it makes it a little more concerning to me as well.
Yeah. And frankly, a lot of these patients, even in the ER, will have a normal EKG. And if this patient came to me in my evaluation in the ER with an EKG and a chest X-ray, and maybe some labs was normal, I would still not clear them for returning to activity from the ER. They would get a cardiology referral, and kind of strict instructions not to do anything. I don't want that on me, these situations can be kind of like a heralding or like a warning kind of shot before, like I said, the worst thing happens. So often, very often, my evaluation's negative, and I still don't let these kids go back before going to cardiology, getting an echo, getting another formal evaluation. Sometimes I get a Holter monitor or something else as well.
From a destination perspective, and Lauren, maybe you can weigh in on this, but so this literally happened like across the street from Westchester Hospital. I still would probably have this kid go up to Children's Liberty, would be my thought, because of all the complexities and nuances of like pediatric cardiology follow-up. She's like arresting in front of you, a different conversation, but like I feel like with like probably heightened level of suspicion by who they're going to see in the ED, and then kind of access to follow up. I think, and granted, it's not like Children's Liberty is that much further, but I'd probably make that couple-minute drive up there. But I don't know, Lauren and Alex,
Yeah, I
what do you
think
guys
the
think?
additional resources is worth the extra exit.
Yeah,
In
I
this
kinda think
case,
so,
so, she's not like a significant trauma or like Dr. Richard said, an arrest. So she can use some of those additional resources that children provides with their like medically complex follow-ups and clinics, stuff like that. So.
But Alex, that's a pretty reasonable, I mean, I know that you work up there, so that's a pretty reasonable ask of them, I feel that, right? Pretty bread and butter.
Oh yeah, absolutely. And again, like I do not feel comfortable with all of these, nuanced EKG findings. Like I have my things that like if I see it, will definitely, I got a problem. But sometimes I'm like, I don't know that, it's just not totally normal. I can't quite put my finger on like exactly what may be going on, but it's not a perfectly normal EKG. And I'll have cardiology look those over with me in, during the ER encounter. And sometimes they have, helpful things like, oh, this is pretty typical for like this age group or this, type of patient or something like that. I've had some of those conversations, but still like rare enough and unique enough that I, I can't call it normal just on my end, or like a normal variant, right? That's a stressful word to me, normal variant, like it's a normal variant until it's a not normal variant, but they're very helpful, and they'll look things over with us right from the ER. Yeah. But definitely like a 12-year-old, I think for sure, children's is the right place. 16, 17, 18, I think you can make an argument for, you know, an adult-sized football player, if they really wanted to go to Westchester. I wouldn't necessarily fight that, but especially, you know, preteen, I think children's is the right place. All right. Awesome. Thanks for the discussion, guys. Okay, so we're gonna finish out talking about a burn case, and again, use it as a chance to talk about some of the kind of protocol and thought process behind burns rather than any like particular issues with the case. I don't think that I would have done anything differently, but it seems like it was a pretty major burn, and just gives some interesting points to discuss. So this was a dispatch to an equipment fire. The medic crew arrived and found the patient standing outside of his business, obviously burned. He had burns to his face, his neck, both hands, both forearms, and the ankles. His eyebrows were burnt off. Lots of hair on his head was burnt as well. But he was able to walk into the medic unit. And at that point, all of his clothing was removed and assessed the full extent of his burns. He had about 10 to 15% of first and second degree burns on the areas that were mentioned. And the patient stated that he was trying to shut off a tar kettle when that was on fire when a hydraulic line exploded, covered the patient in fluid, which sounds like absolutely horrific. And the patient was engulfed in flames, and shortly thereafter was able to put himself out, thankfully. The patient's skin was gray and black and was swelling, also starting to blister on the face and hands. And the worst of the burns were on the face and hands. Had good perfusion, no other injuries, got an IV and gave some fluid, gave ketamine for pain. Vitals were okay, except for hypertension, which the patient was known to have as a past medical history. And a burn sheet was placed over the patient. The patient did not have any signs of inhalation injury in or around his mouth, but did have slightly singed nostrils bilaterally. There was no bleeding or from any of the injuries. And vitals were like nicely hypertensive, 170 over 100, heart rate of 80, respiratory rate of 22, 99% on room air, a blood glucose of 110, and a GCS of 15. So a couple of things about this documentation that, again, I think just demonstrate kind of your guys' understanding of how we think about burns and classify them. So kind of being specific that the patient had 10 to 15% of first and second degree burns. This is absolutely correct. You don't include third degree burns on the on your estimated total body surface area. So it only includes first and second degree burns, which are your deeper burns, right? Oh no, sorry. I got that backwards, didn't I? Second and third degree are actually the ones that we want to include. So your partial thickness or deep thickness burns, the burns that just look like a sunburn actually don't get included on your total body surface area assessments. They might become deeper as time goes on. Like even here, you know, it's indicated that the patient has like evolving blisters. So that total body surface area is kind of like a continual reassessment in burn patients, but you just want to, you know, go based on the deeper burns that you see. And then we're going to talk about kind of the thought process around, you know, which patients have inhalational injuries and when you need to intervene. But this patient, you know, clearly was ambulatory, alert and oriented, you know, able to do all the interventions you needed to do, and like a perfect oxygen saturation on room air, without, you know, other signs concerning for, you know, evolving upper airway swelling or edema. So appropriate not to intervene on this patient's airway. The protocol includes basically everything that that was done, and then a discussion of kind of more advanced management. So getting the patient away from the fire, obviously. If they're hypoxic, administering oxygen. If they're pulseless, this is another group of patients where early intubation is favored over other airway adjuncts. Obviously start CPR and then moving quickly towards intubation. And if they have signs of respiratory distress or unconscious, even if they're not pulseless, again, an indication to think early and move toward intubation earlier on. Covering the patient, which you guys did, getting some IV resuscitation, treating pain, all very appropriately done in this situation. And then toward the end here is a kind of a consideration of carbon monoxide poisoning or cyanide poisoning, and then kind of referring to the protocols for those two things. So we will talk about those a little bit. First, just a reminder about how to assess total body surface area. In adults, you have the rule of nines that you can follow, and there is actually like a little diagram in the protocol or the palm method. Just remember, this is the patient's palm. So like if you were to, put their hand on their body, how that each palm is 1% total body surface area. Recognize that the rule of nines that you're taught does not apply to kids. They have big heads and little extremities, and so the percentages are out of whack when it comes to pediatric patients. So for peds, I usually prefer to use the palm method to help assess total body surface area. Obviously, if it's like a huge amount, the nuance of like, is this 10 or 15 matters a lot less. It's more than 30, that's fine, but for a small body surface area, I like the palm method for kids. And so then there's the protocol says to think about intubation early, but doesn't really give you kind of like great guidance on like what you're looking for. And this is, I think, has been a moving target over the last 10 or 20 years. And so for those of you who've been practicing longer, these recommendations might have changed a little bit over time. It's good to recognize that even patients with obvious facial burns like this or signs of inhalational injury, a relatively small percent of them actually need emergent intubation. A slightly higher percent might get intubated over like the next 24, 48, 72 hours if they're admitted, or when they're admitted. But there's a relatively small percent that will need emergent airway management. But intubation is indicated if you need to oxygenate, ventilate, or maintain a patent airway for a patient. And so the patients to consider this in are patients with significant facial or neck burns, any blistering or swelling within the mouth, any stridor. So stridor is that kind of high-pitched noise when they breathe in, and that's a sign of upper airway swelling and obstruction. Any signs of respiratory distress, so retractions, or if the patient is not ventilating appropriately. And also in patients where you're kind of unsure whether or not their airway is stable, is a person to consider it in. The challenge here, I think, in the pre-hospital setting and with kind of what you guys have available to you, is that we don't have you do RSI. And so for someone who has, significant burns and you're worried about, this point of like the stability of their airway, until that patient's unconscious, you're limited in what you can do. So you have to support their airway otherwise. Obviously, if a person is unconscious or in cardiac arrest in the setting of a fire or either burns to the face or a fire where you're concerned for inhalational injury, then again, these are patients where you want to go to intubation early on and think about a smaller tube than you would typically. Again, with a bunch of swelling in the back of the throat, a supraglottic may not seat very well, and is not going to prevent kind of progression of the swelling. An ET tube also is not going to stop the swelling, but it's going to stent the airway, you know, fully in the airway. And so you're going to actually be able to maintain that patent airway better than you can with any kind of supraglottic device. So that's the airway management in these cases. The next thing is kind of what else to be thinking about. So just a reminder that there's kind of two different compounds that might be affecting a patient. In the case of an inhalational injury, on the left is carbon monoxide. I know you guys think about this in a lot of different settings, but carbon monoxide basically binds to hemoglobin more effectively than oxygen. And so it stops oxygen from binding to your red blood cells. And so you can't deliver oxygen effectively to the rest of your body. And the treatment is just a lot of oxygen. There are more like advanced treatments after that person gets to the hospital, but in the pre-hospital setting, just lots of oxygen. Cyanide toxicity is for patients who have inhalational injuries, usually in the setting of either like some sort of contained combustion or closed space fire, where there's basically synthetic material that's burning, and the cyanide is made from the burning of that synthetic material. And the cyanide basically stops oxygen that's bound to hemoglobin from working, and again, in effect, stops you from being able to get oxygen to your organs and deliver that effectively. The signs are pretty similar for both of them. The history might give you a clue. Again, cyanide is, you know, typically has to be sort of enclosed. You really have to be breathing it in. And carbon monoxide might be is going to be more common in a wider range of fire situations, but they can present kind of similarly. Treatment for carbon monoxide is oxygen. The treatment for cyanide is cyanokit. And maybe Chief Hartley, you can tell us which, if any, of your crews have cyanokits available to them or where they are.
So we do not currently have any. They are looking at trying to do a group purchase of them, and the closest one that we have available to us is Liberty Township.
And then the other option would be Dr. Richardson and I discussed would be air care. If you need to get a cyanide kit. So the thing to kind of realize about cyanide toxicity and kind of when to give a cyanokit is basically any patient who has CNS depression, so altered mental status after being in an enclosed space fire, signs of shock, so hypotension, tachycardia, and there probably is some role in cardiac arrest. It's a little bit of a Hail Mary, but I think most people would agree that a cardiac arrest patient who was in a fire like that probably warrants a cyanokit. And this is not just your patients, this is you guys as well, right? So if you have a team member that goes down in the context of fighting a fire, we want to think about a cyanokit for them as well. And again, kind of, you know, over time, you know, it'd be good to get an update of what the status is with you guys having the cyanokit directly available to you, as opposed to needing to call in air care or other resources. The reason that you don't have them is that they are super expensive and you don't use them very often. And so it's a tough purchase to kind of swing in that regard.
Yeah, we got money. We could do it.
Awesome. It's, you know, a lot of them will expire, you know, that's a challenge. So the cyanokit is its own, it comes as its like own enclosed box. And if you guys do get them, like, it would be great to do trainings on them, because although there's instructions on the box, they look like this, which are kind of weird and unhelpful. But it actually comes as a powder in this like glass vial that you have to reconstitute with 200 cc's of normal saline. Then you kind of like gently mix, which is what all these arrows are trying to show you, but gently mix the vial and kind of get that powder to dissolve. And then it comes with its own connection tubing, because they have proprietary tubing. Otherwise the it's basically just a lot of vitamin B12, but it leaches into regular tubing. So you have to use the tubing that comes with the kit, and you have to use a dedicated IV line or IO. So nothing else can be going through that. You could have given something before, like if you're in a cardiac arrest, you could have given epi and then flushed it, but you can't be giving other meds at the same time as the Cyano kit. So it needs its own dedicated point of access. The adult dose is the whole vial over 15 minutes. So you just hang it, let it run, and it'll flow in for the most part, unless you have a finicky IO. And then pediatric dosing, the 2024 protocols will have updated dosing guidelines in the kind of pediatric section of the protocol. I did create kind of like a simplified version of dosing for CFD that if you guys are interested and you want to include that when you get the kits, it's loosely evidence-based in that you basically can't overdose anyone on this medication, but it's very simplified to kind of like small, medium, and large human beings. So I'd be absolutely happy to share that if it's something that would make kind of the stress around the situation. Obviously, pediatric patient in a house fire where you're, doing a cardiac arrest and giving a Cyano kit, there's a lot going on. So simplifying that is always good. I'd be happy to share that. And then this is just the actual like protocol information from that toxicology protocol, where this information is. It's a lot to read. It's kind of painful, which is why going through it, knowing what it looks like, getting your hands on practicing with something like the Cyano kit, when you get access to it is super important. And that's all I got. I think we're pretty much like right at 2:30. So anything else, Chief Hartley or Dr. Richards, about the CQI?
So Lauren and I were over here, actually the hospital put in a bunch of pictures, so I can show you the pictures of where we started and where we're at now if you want.
Yeah.
Are you the host right now? Can you switch over to, or can you let me in?
I stopped my sharing, so hopefully that means you can.
Oh, just so I can bit me to the, yeah, you see, I can show one over there, yeah.
Get your own computer in, yeah.
Maybe.
My like personal story while Dr. Richards gets this up is that when I was probably like 14, 15 or something, I was doing like a sailing course or something like that, and the person that I was with was trying to light an alcohol stove in a boat, like in a sailboat in the central part of the boat, and like it wasn't lighting, so he kept adding and pouring alcohol in while trying to light it, and the whole thing blew up in his face caught on fire, all the rest of it. And so like reading through this case gave me a little bit of PTSD back to that situation. Our solution was just that we threw him overboard and threw him in the water, and I got the fire to stop. It wasn't necessarily the cleanest way of dealing with his burn wounds, but it got the fire to stop. So
let's see. Alright, so this is where they started.
thanks.
So you guys, that's bold. I commend the crew for, really testing for more hard signs of deeper airway inhalational injury. Cause yeah, if he's like speaking fine and doing all the rest, I would have gotten, you guys appropriately were a little bit nervous about this, brought him right to the trauma bay. So what they did actually is rather than just intubate empirically or anything like that, they actually did a nasopharyngeal scope. So they went down and actually took a look at the cords themselves, saw that they were totally fine, no problem. Just watched them. They did transfer him out to UCMC, the burn center. He got discharged a day or so later, totally fine, never got intubated. So when I think about like eyelashes and all that, eyebrows getting burned off, I'm like, oh, clearly the next step is going to be airway, and especially for longer transport times, or if there's other symptoms, like that is definitely a hard connection. But I think this is a good case to show, like, you can't get a flash burn to your face. Give it 7-minute transport time. you know, let's make that transport and see if they can take a look with an MP scope and see if we can get by. So really good approach here. And I think if it was a 45-minute transfer time, maybe a different conversation, but I think for this situation, I think perfectly spot on. He had a clinic visit just like 3 days ago, and this is kind of current state of affairs. It looks done better, a little bit of eyelid kind of stuff, but night and day difference compared to when this all started, so. Good job.
It's incredible.
You know, it is.
Thanks for showing those. Cool. Any questions, guys, about the stuff that we talked about today? Sweet. Well, thanks for your attention. Sorry for the extra 3 minutes. But really appreciate you hanging out, and hopefully it was
It was
good.
gonna happen at any point during the conversation, and that was a good time to happen. You froze there briefly, Alex. I don't know if you had any other concluding thoughts for us.
Oh, no, that's all I had.
Cool. All right, nice job. It's great. Good cases. Good discussion.
Cool.
Awesome. All right. Well, thanks for everybody for tuning in today.
Thanks, everyone.